Julia, I'm going to try to do a quick review, or at least as quick as I can, over Unit 5. Unit 5 covers our affective disorders and schizophrenia, so depression, bipolar, and schizophrenia. So this is a lot. So when we talk about our depressive disorders, we're going to start with a few different types. Persistent depressive disorder used to be called dysthymia. So you may remember it, have heard of it as dysthymia, but this is someone who's just down in the dumps. Like they are super depressed most of the days of the week for at least 2 years. And they tend to have these very self-critical, maybe down on themselves. They're very negative. They might talk or move slow, have trouble with hopelessness, self-esteem and energy. You know, in class we watched a little bit about this because it's the perfect Eeyore, right? This is someone who's just like, you know, not much of a tail for not much of a donkey. And no matter what happens, he's just, no matter how great his friends are, he's still just down. Premenstrual dysphoric disorder is pretty much straightforward, but we think it is. This is serious enough to disrupt functioning. If it is not disruptive functioning, we do not give it the disorder. But this is within usually about the week before menstruation starts. We have these extreme mood swings, depression, anxiety, lack of energy, right? Insomnia, bloating, weight gain. Treatment is a lot, maybe hormone regulation, diet. We could do some light therapy, relaxation. But the hallmark of this is it's in the week leading up to menstruation, it is enough to disrupt functioning. But then once menstruation, happens, it goes away. Some other depressive disorders, substance or medication induced. You are drinking alcohol and you wind up with depression. And when the alcohol goes away, the depression goes away. We should never diagnose psychiatric conditions when someone is under the influence or actively using, because if the condition goes away, then they do not necessarily warrant the diagnosis. We also can have depression due to a medical condition, vitamin B12, Alzheimer's, post-stroke depression. The medical system or condition occurs, and that causes a depression. Our big one that we're talking about is major depressive disorder. So this is someone who is going to have either depressed mood or loss of interest or pleasure, along with some of these other symptoms. And we can see this is from the DSM, that it is great weight loss or weight gain, insomnia or hyposomnia, psychomotor agitation, psychomotor retardation, right? Fatigue, worthlessness, guilt, inability to concentrate, and then recurrent thoughts of death. So these symptoms are going to be present during the same 2-week period, and the symptoms can kind of keep coming on. It does not have to be just 2 weeks. It can also be longer. A few differences in age. Most of the time in children, adolescents, it's going to look the same. Young children are more likely to cry, while their older kids are going to be irritable and angry. With our young children, they tend to have a lot more of the guilt, and they tend to internalize external events. So kids are more likely to be like, my mom and dad are getting divorced and it's all my fault. And that external event is contributing to the depression. Older adults, we do see quite a bit of depression, but we have to remember it's not a normal part of aging. When we get into the older adult, we are going to talk about this in much more detail. However, the big thing is we cannot overlook this. We can't just be like, well, they're in pain or they're old. Of course, they're supposed to be depressed. We have to investigate, and we have to make sure and kind of see that there's nothing else going on. So when we talk risk factors for depression, females, especially in the mid-20s, and to see higher rates of depression. We'll go into adverse childhood experiences a lot. I think it's Unit 6 when we talk about trauma, but these are 10 specific trauma events, and when they happen before the age of 18, they just have these major repercussions throughout our life. If you have a stressful event, if you have a first-degree family member, and we're going to talk about the diastasis stress model next, so hold on to that thought. If we have that negative personality, that negative Nancy, someone who is just always kind of looking at the negative, they tend to have a higher risk. We do see depression comorbid with other mental health conditions, substance abuse, anxiety. If someone has generalized anxiety disorder, that anxiety sometimes continues until they become depressed. Chronic or disabling medical conditions, especially chronic pain, greatly increase our risk of depression because of how it's affecting our life. So the diastasis stress model, We have talked about this before. It's kind of very central to today's lecture when we talk about these risk factors. You have that first degree family member. You have an inherited predisposition to develop the disorder. But if nothing happens and you have a great life, there's no trauma, there's like minimal stress, you have a very low chance of developing the disorder. However, if you have that inherited predisposition, and then we have childhood trauma, that increases your risk of developing the disorder. This is very much how we could have two siblings, right? Let's say mom had depression and we have two siblings. They both now have inherited that predisposition to develop the disorder. One sibling has a history of childhood, let's say like abuse, right? When she was an adolescent, she was raped. That can increase her risk of developing the disorder. The other sister has the inherited predisposition, but does not have that environmental, right, outside stress. Without that outside stress, that psychological disorder might not manifest. This is how two people can go through the same type of like trauma, the same type of event, and that will have different outcomes. Our cognitive theory is one we're going to talk about, and we've talked about cognitive theory quite a bit this quarter. This is when our thoughts and our feelings are going to influence our emotions. When we look at these thoughts and feelings, we're going to look at the negative, and we're going to constantly focus on the negative. I'm not smart. I'm not a good person. I can't do this. I don't understand. I'm not good at this. It's just not going to work for me. And we focus on that negative. We have that very fixed mindset, and we're going to be like, I don't know how. Instead of saying, I like to try new things, I'm going to learn. And those negative thoughts really do affect us over time. When we're assessing a client with depression, a few things we have to look for: suicide. We always, and honestly, not just our depressed client, all of our clients have to look at suicide. Are you having any thoughts of suicide? Are you having any thoughts of killing yourself? Are you having any thoughts of death? Would you be better off dead or alive? Like, do you have more reasons for living or dying? We have to do a very good and thorough suicide assessment. We'll look at the PHQ-9 on the next slide. Different things we are going to see in this patient: depressed mood, sleeping too much, not sleeping, eating too much, not eating, guilt about everything. I'm not good enough. I just can't get this. My kids would be better if they had a better mom. Helplessness, worthlessness, hopelessness are central to depression. We tend to see that. I'm just not good enough. There's no hope. I'm always going to be like this. And those especially we tend to see with suicide too. Chronic pain is when we have to look at. Chronic pain leads to an increase in depression and an increase in suicide. And then affect versus mood. What is on their face? How is their face looking versus what are they saying? So this is the PHQ-9. It is a standardized assessment we can use to look at depression. We can see little interest and pleasure in doing things, poor appetite, overeating, tired, trouble concentrating, moving so slow, or being excessively fidgety. So we're going to ask the patient, does this happen not at all, several days, more than half the days of the week, or nearly every day of the week? And then we will get their score, and it will kind of rate how serious their depression is. So when communicating with a client with depression, that cognitive slowing does occur, so sometimes we have to use silence. If we ask a question, it may take them longer to process it. Making observations can be helpful. I noticed you crying. Can we talk about how are you feeling today? And then just like when we talked about anxiety, simple concrete words. We don't want to talk too much. We don't want to use long, convoluted sentences because it's going to take clients time to process this information. So we want to be nice, relaxed, and straight to the point. If we're talking about suicide, we have to directly ask, are you having thoughts of killing yourself? Are you having thoughts of suicide? That covert message, my family would be better off without me. And if our client says my family would be better off without me, that is where those clarification techniques. When you said that, can you tell me what you meant by it? And then again, those cliches. Everyone's going to be okay. Everyone goes through a hard time. For patients with suicide, this is not always just down in the dumps. It's not always just hey, I'm really sad. This is an extreme. This is different. And when we talk about this, we're going to think this person, they're at the bottom of a dark hole and there is no escape. There is, this isn't a hard time. This is the worst time. So we have to avoid those cliches. When it comes to health teaching and promotion, we have to remember this is beyond voluntary control. No one is choosing to become depressed. We do have physiological, pathophysiological changes that occur during depression, right? Decrease in serotonin being one of the simplest. We do have to treat this as a chronic illness. If you had depression when you were younger and you kind of got over it, you're more likely to see it come back later in life. If we're talking about medications, letting our patients know when you start feeling better, you can't just stop the medication. And to do that, we talked in class how I love strep throat because 24 hours later, antibiotics, my family is all better, right? Compared to a long-lasting stomach bug or the influenza. So if we have someone with depression, we start them on the antidepressants. Just because they're feeling better does not mean they need to stop. They need to definitely talk to their doctor. Some people can stop their medications and be okay. Some individuals, it is not a good idea, or we need to closely monitor them during that time. Nutrition, exercise, coping skills. We have talked about that quite a bit throughout this course. We have to have a healthy foundation, right, in our body in which to build our mind. Our gut is connected to our brain. Our gut makes serotonin, right? Exercise, endorphins make you happy. Skills. What are things that bring you joy? I am going to kind of skip through our medications. I'm going to do a separate video on some of these medications. So I am skipping them. I know. I will go back. I promise you will have a video on that. So antidepressants in the older adults, polypharmacy is a big concern. Sometimes something to stay on them, especially our elderly. And now we're trying to see like, well, why are they still on them? TCAs and our MAOIs do have some dangerous side effects. So they are not our first choice. We have to be very cautious in the older adult if they are on that. Our SSRIs tend to be our first line for everyone. However, even with those SSRIs, I'm going to take the lowest adult dose. So if I would normally start an adult on 25 milligrams of Zoloft, I'm going to start my older adult on 12.5 milligrams. And we'll do 12.5 for a little bit and see how that works. And then after, maybe a month, for 2-3 weeks, we would increase to 25. Slow and steady. EC has a bad rep, but it is highly effective. We do use this as a primary treatment in patients who are not responding. That is our big one. You're not responding to SSRIs, SNRIs, TCAs, MRIs. We have done all of those, and it is not working. Generally, depression is where we see this. We could see it in that depression associated with bipolar. We can see this sometime in schizophrenia with catatonia. So we have this bad rep from ECT because we are all thinking about Nurse Ratched and One Flew Over the Cuckoo's Nest. If you haven't, you actually can just go on YouTube and watch the little video of ECT in One Flew Over the Cuckoo's Nest. It is not very pretty. But that old school 1950s, 1960s, 1970s mindset of how ECT happened is what we tend to think about. Nowadays, ECT is done just like any procedure. If y'all are going in for a colonoscopy, it will be very similar, just as similar, and honestly probably safer to do ECT. So what we're going to do in ECT is our patient will have a procedure, and they're going to be NPO, just like any other procedure we're going to do. So for 8 hours ahead of time, they are not going to eat. They are going to come in a little bit before their scheduled time. We're going to prep them, right? Get vitals, make sure they're nice and stable. During the procedure, they are hooked up to an EEG and an ECG. We got a BP cuff going on. We got pulse, right? Pulse ox, respirations. We are monitoring you. We are going to give some type of sedative, muscle relaxant to calm you. The whole point of ECT is to cause a grand mal seizure. I am going to give you that muscle relaxant to chill you out so that when that seizure occurs, it doesn't look like a grand mal seizure physically. We will see the grand mal seizure on the EEG within your brain waves, but not in your body. We might see a toe twitch. So we hook you up, we cause this seizure. It'll last about 30 to 60 seconds. Afterwards, our patient will be post-ictal. They can be confused and disoriented for a little bit. Oftentimes, there's memory loss related to that specific procedure, that specific time. Not often, but it can occur. our patients can have something called a retrograde amnesia. And in retrograde amnesia, they forget things that have happened in the weeks to months, days previously. Now, ECT can be safe for almost everyone. Right? I was once told if you have a working heart and a working brain, you're a good candidate for ECT, which honestly is mostly true. If we have someone with any major cardiac concerns, I don't want to do ECT because that is going to stress the heart. If I have someone with like a brain tumor who just had a stroke, I would not want to do ECT because it is putting stress on the brain. Few other people we may have to be considerate about if we have someone with a seizure disorder. If I have someone with a seizure disorder and they are on an anti-epileptic, a benzo, Depakote, I would have to stop that seizure medication prior to doing ECT. Because if you're on a benzo, I will not be able to cause a seizure, so there is no point to doing ECT. They cancel each other out. But for the most part, after this procedure, within an hour, the patient will be going about their life. Most patients need a few treatments. You will have to come in a few times over a few weeks, get your ECT treatment, and then you do okay. Some patients, we talked about Carrie Fisher in class, Princess Leia, she needed routine, regularly scheduled maintenance for her ECT, where she would go back every so often. I have a few other different types of treatments. Transcranial magnetic stimulation. This is a newer one. I say newer, but honestly within the last 15, 20 years. It is that top picture that we see there. It is like sitting in a dentist chair. They map your brain and they send magnetic impulses into the brain, and it stimulates that part of your brain to begin producing neurotransmitters. Works very well, minimal, especially compared to ECT side effects. Headache is one of the big ones after, but that's really about it. You do have to go in every day for a few weeks because it is a magnet. It is not as big as an MRI. It is tiny, however, it is a strong magnet. We have to be cautious with any metal. This isn't like, if you have a belt on, you can't do it because we are focusing it. But if we have someone with a plate in their head, or if we have someone who is deaf, who has a, what's it called? I'm going to think of the name of this later. And I'm going to look up the name. Okay, my brain today, y'all. If it is a cochlear implant, that is what it is. It is a magnetic metal device that is implanted in the head to help individuals who are deaf or hard of hearing hear. Those are the things we're going to have to be concerned about with the transcranial magnetic stimulation. We would not want to go do it. Vagus nerve stimulation, deep brain stimulation, I talk about them very briefly because they're surgery. We are surgically implanting, does not happen often. Light therapy is an interesting one. We don't see this often in Texas. Y'all sometimes will ask me all these questions, but again, this is not a Texas disease. We do light therapy for seasonal affective disorder. And seasonal affective disorder is sometimes called a winter depression. And we tend to see it Halloween through Valentine's Day, Easter. And the sun sets in the winter, and individuals, some are depressed. We tend to see this more who live in our much northern hemisphere, Washington State, Canada, Alaska. Good and bad to light therapy. You wake up, you sit in front of this sunlight for 30 to 45 minutes a day. It can cause some jitteriness and headaches from being exposed to the light, but for the most part, it is generally safe. St. John's wort is over the counter. While it can increase dopamine, serotonin, or epinephrine and help with depression, it interacts with a lot of different things to include our psychiatric medications. So we got to use cautious when we're using anything over the counter. Exercise increases availability of serotonin, right? It increases your endorphins. It makes you happy. And then therapy. Therapy is always a wonderful option. Okay, we're going to go into bipolar disorder, and I know my slides are a little bit backwards than how some of y'all's were in class. So when we talk about bipolar disorder, bipolar disorder is a condition where our patients kind of swing back and forth. We have depression, which we've just talked about, and then we have something called mania or hypomania. So mania is our worst one. This individual does not need sleep. Right? Their words are going to be flying out of their mouth. They're going to have that pressured speech, that word vomiting, and they're going to have that flight of ideas where they're going from topic to topic to topic. And you feel happy. Some individuals where it says treatment resistant, I've had patients describe their mania as like their drug. I'm more creative. I can get more things done when I'm manic. So they like being manic. These patients tend to push limits. They will be driving 150 miles down the road and not think anything about it. Now, just like most of us, and a lot of times when we talk about mania, we're going to think about our toddlers. If I have a toddler who is not sleeping, eventually they become very agitated and irritable. Lack of sleep, too, can cause hallucinations, can cause a lot of that psychosis. So our patient starts off in that initial stages of mania is really happy, but then they give way until this exhaustive collapse where they're agitated, they're irritable, they're angry. This individual has these grandiose thoughts. Nothing is too great. They can do everything. We had a patient at clinical this week, and I know we talked about it in class. He was like, I've done this, and I've done this, and I'm going to write a book, and I've been an EMT, and I've been a truck driver, and I was in the military, and he had done all this stuff, and timeline-wise, none of this worked. This patient is going to have this inflated sense of self in that they are amazing, they're awesome, they can do all. We can often see it in how they dress. Lots of makeup, lots of over-the-top clothes. This mania will eventually give way into a depression. Your patient just collapses. We also have something called hypomania. Hypomania tends to get overlooked and not get diagnosed because we think this is someone who just has a big social appetite. We think this is like that fun friend who is like, hey, let's go on this road trip. We can do this, and they're going to be the life of the party. They're going to spend a little bit of money, but honestly, our manic patients will spend more. They're going to have indiscriminate sex, but our manic patients are going to do it worse. Like hypomania is small. They're usually not hospitalized. They usually don't have the agitation and the psychosis. They just have a little bit more excess energy. Well, our manic patient is not sleeping at all. A hypomanic patient might get like 3 hours of sleep. So our first bipolar condition, and we have 3 we're going to talk about, is bipolar 1. This is the most severe. You will have that one manic episode, so happy, optimistic, euphoric, not sleeping or eating, engaging in hazardous activities. As this continues, as we are not sleeping, as we're not eating, our thoughts get disturbed and we can become psychotic. We hallucinate. Eventually that exhaustion, right, that hangriness comes into play. Our patient winds up agitated and irritable. They are dangerous. Eventually, they collapse into depression. We see an increased risk of suicide. In mania, we might see danger to self. We might see suicide still. So it can be both. So this is kind of our little representation with bipolar 1, mania going all the way to the top, as high as we can get. Our energy is all the way up there, and then we drop down all the way to the floor. We watched our little video about Mrs. Kitchener, right? Her clothes, her apartment was very chaotic, very exaggerant, right? She had the flight of ideas, that pressured speech. She just kind of like walked up to the nurse, was like, oh my God, your earrings, and was touching her head and her ears. She got into the personal space. She kept changing the subject, right? And she kept talking. The nurse could say nothing. That's that pressured speech and flight of ideas. So bipolar 2 is our second condition. This is hypomania mixed with depression. This again is not often diagnosed because we think this is someone who just has a big social appetite, and it doesn't really increase or cause a disturbance in function. Socially, occupationally, we're doing okay. They're not as severe, and the episodes tend to be shorter. So we can see in bipolar 1, we still have that risk of depression, but that mania isn't going all the way up. It's just kind of like a little blurb. And also because true mania can last like a week or so. Hypomania might just last a few days, where this person has tons of energy for that weekend trip, that weekend vacation, that all of a sudden they're going to spontaneity, right? They're going to plan, and then it disappears. You watched our friend here, right? Everyone loves her. She's beautiful. She's funny. She slept for like 2 or 3 hours. So we can kind of see our comparison with the white being bipolar 1, going all the way to the top and all the way to the bottom. And then bipolar 2 is just a little blurb of mania. Our last condition we're going to talk about in our bipolar type disorders is cyclothymic disorder. Also, sometimes you'll hear it called cyclothymia. So this is hypomania with a moderate depression. So we can kind of see it's at least 2 years where we're going to have these periods of hypomania depression. And it's kind of going to continue. We tend to think with cyclothymia, they cycle, so the symptoms are happening more frequently. But they will go with a tiny little bit of like mild depression and then into that hypomania. Mild depression, hypomania. Again, not quite as disabling because hypomania versus mild depression compared to that full mania we see in bipolar 1. So when we are assessing these patients, we got to look at their mood. Mood is oftentimes labile. They'll be happy, they'll be sad, they'll be angry, they'll be happy. Like, it is changing quickly. It is very emotionally unstable. If we have someone in mania, they're very euphoric, that irritated, agitated, uninhibited type behavior. Again, hypomania, lots of social engagement, spending money, get-rich schemes. While in mania, we're spending more money. We're super distracted. We're pushing all the limits. We talked about some examples of thought processes. Pressured speech, we saw that in Mrs. Kitchener where it was like urgent. You couldn't stop them. We couldn't resist commenting. Flight of ideas, I know that's down the bottom. We kind of also saw that with Mrs. Kitchener. We're moving rapidly from one topic to the next, to the next, to the next. And you're like, how did we go from I could be lying here and dying to like my ex-husband's at Taurus? She was just all over the place. The hypomanic video we watched, that is where we tend to see that circumstantiality tangentially, that loose associations. Tangentiality, we wander off topic slowly without ever reaching the point. It is not quite as bad. Circumstantiality is kind of the same. We're going to give extra details, but I will eventually reach the point. So circumstantial, extra detail, but we eventually reach the point. Tangential, we wander and never reach the point. Loose associations is very similar. It's kind of, I always think of it as like flight of ideas light. We're moving from topic to topic, but it's not at such a great speed. Clang associations tends to be rhyming. Our patients are going to be talking like Dr. Seuss, and everything they say will be a rhyme. When we're assessing these patients, we have grandiose delusions. Hidden buttons. Grandiose delusions, I'm better than everyone else. I have millions of dollars. I'm super smart. Persecutory delusions. I have come up with this plan to harness all of this energy and create this amazing energy source that will solve all the problems of the world. And the CIA is tracking me and they're trying to steal my ideas. Right? Sometimes we can see where I have done this wonderful thing, this super grandiose, and now someone is out to get me. Overall cognitive functioning can decline when we are talking about the number of manic episodes. The more manic our patient is, the longer these manic episodes are going, the greater the risk of overall cognitive decline. Big guidelines always danger to self or others. And again, it does not always have to be suicide or like homicide. It could be driving recklessly down the road where we're just not thinking in that situation. Patients may need protection and may get hospitalized because they are unable to do their ADLs, because they're not eating, drinking, or sleeping. Medical status is a big thing that we're looking for because it's just not safe to be starving yourself and not sleeping for a week and not eating for a week. These patients put themselves at risk without knowing it. Family support and knowledge is hard because, again, no one wants a big mental illness. And when we do tend to see these diagnoses, families just struggle. So making sure everyone kind of knows what is going on, what to look for in that patient, and what they can do to best support the patient. Our interventions will always follow Maslow's. At the simplest, just like, we talked about depression, calm, right? I want to say this is like the exact same sentence. We're going to be calm, short, firm sentences, straight to the point. As a team, we need to be consistent. If I let a patient get away with that and then T comes on to work and T's like, absolutely not, like this is what's going to happen, these are the rules. It creates an inconsistency in that milieu, which is hard for patients. Want to have structure. Patients, especially with our severe mental illness, do better when they know what to expect. Decrease the stimuli, and we want to make sure we're providing high calorie foods and drinks, oftentimes finger foods, right? High protein. So ensure like half of a sandwich, a granola bar, a protein bar. If this patient comes up for meds, I'm going to be like, drink this whole cup of water with your meds. Aggressive behavior, oftentimes, and this is going to be tricky, we can redirect it. We'll talk about restraint and seclusion in a few slides if we get to that point with the patient, but hopefully we're recognizing and we're involved enough that when the patient starts to escalate, we can redirect them into a different activity. We want to keep everything free from harmful objects. INO, food, again, is one of our priorities with this patient's simple safety stuff. Simple safety stuff is what we have to think about. Like, this patient's a fall risk. I've seen bipolar patients running up and down the hallway and they slip and fall because they don't got those grippy socks on, and then they break, they bust their head on the floor. So oftentimes we do have to think at the simplest. So when we're talking about those interventions for mania, we want rest periods. We want to give our patients a time to kind of go and chill. Especially on our more acute units, our PICU type units, we're going to give the patients a little bit more access to their room. Because if they have been manic, if they haven't been sleeping and now they're going to bed, we're going to want to let them go to bed. Promote that relaxation. If they fall asleep on the floor, I'm just going to let them sleep on the floor too. We're not going to wake them if we don't have to. Hygiene, we want to make sure that they're showering. We want to make sure when it says appropriate clothing choices, especially just for weather. Constipation can come because we are not eating or drinking, so we just do have to offer foods high in fluid and fiber. Again, I'm going to do meds in a separate slide, so I will cover them, I will promise. Seclusion and restraint. We have to make sure we are consistent and have a plan on these patients. We have to make sure that if the patient is taking meds, that we are giving them and keeping them on board. That we notice when they start to escalate, because when it comes to aggression, the best thing to do is to get in there early. Seclusion and restraint cannot be ordered, scheduled as an intervention. It has to be a last resort when the patient is out of control in that emergency. This is a code. Right? We're just not going to call a code because someone yelled at us. Like, they have to be extremely aggressive. They have to be swinging. And we have to have something else first. Do they get along better with a certain staff? Right? Sometimes there is a nurse who has a great relationship with the patient, and that patient starts escalating, and the nurse or even the tech oftentimes it is the tech, can come and de-escalate. Seclusion and restraint is only used for safety. When it comes to health teaching and promotion, we want to look at our warning signs. If we have someone who has been stable, but all of a sudden they are sleeping less, if they're not eating as much, if they're not staying compliant with X, Y, and Z. Right? We have to look at their risk of weight gain. Some of these medications can cause weight gain. We have to make sure we're talking to the family, making sure not just the patient, but the family knows what is going on and how they can best support them. We have a few different types of therapy. Cognitive behavioral therapy we've talked about before. It's a lot of working on the skills and the thought processes and the behaviors. Interpersonal and social rhythm therapy helps, one, like I said, stabilize interpersonal relationships. However, patients often do better with that routine. And so it can help get that patient a routine in. And again, family-focused therapy, because we want to improve communication. I'm going to stop here so these videos aren't too long, and I will have a second one for y'all on schizophrenia and then a third one on medications.